and best of luck.
Thank you.
Hello, and welcome to the Q&A session of cutaneous T-cell lymphoma. My name is Heather Gregoire, and I am the Executive Assistant and Donor Database Manager at Lymphoma Canada. I will be the facilitator for this session today. I'm pleased to welcome here Dr. Meenakshi Taparia, who will answer your questions from the breakout sessions on CTCL. She will be stepping in for Dr. Jory Harden, whom you may have seen in the CTCL presentation. As a reminder to our audience members, please type your questions into the Q&A chat box in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. So we can begin. If you have any questions, you may begin now. Okay, so we'll start with the first question. Are there certain genetic factors that increase a patient's risk for CTCL?
No, so far as we know that there are no genetic risk factors that increases the risk. So we don't do any genetic studies at this time. There's some research going on, but currently we don't know of any genetic risk factors. There may be some acquired mutations, but as I said, there is some research going on into that to look if there are some mutations that may be seen in a patient population that predisposes, but currently we have none that we have identified.
Okay, so we'll go on to another question. Are there any dietary recommendations or restrictions that may benefit CTCL patients during or after treatment?
Currently, there are no dietary restrictions or any changes that you need to make to kind of, help with the disease. We obviously suggest because of the medications and treatments that patients are on, some of them can affect their liver. So avoidance of alcohol, staying hydrated for treatments like ECP, those are some of the things, but there's no current any kind of diet that would help to with the management.
Okay. You just mentioned ECP. So how do you decide how often a patient needs to come in for ECP? And does the schedule change depending on how that individual is responding to treatment?
Yes, the schedule typically is, unfortunately in Alberta, it's only in Calgary that they have ECP. We don't have it here in Edmonton. And so all the patients go to Calgary. So typically they do it 2 days in a row and they do it every second week. So they do it for 2 days in a week and then off, and then they do it again the week after. And so they try and do that for a few sessions, at least about 12 weeks of those sessions. And if they see a significant response along with any other therapy that they are on, then they will continue with that for up to about 6 months. And after that, they might decrease the number of weeks. Instead of doing it every second, third week, they may do it just once a month. So it all depends on the responses.
Okay, that's great. In the webinar that we was just watched, they mentioned the global shortage of the Pegasus. And out of curiosity, how was it decided who should or who should be receiving this treatment?
So Pegasus, there is still a shortage of that. And so the patients who were already on Pegasus having good responses, we continued on that. And the new patients depending on their stage of the disease, if they are stage 1B disease and they have multiple lesions that are thicker plaques, we decided those patients would benefit. We did discuss with these patients if they can get Pegasus or if they're open to the idea of getting the alternative treatment that we have available now, which is the Ropeg, which is a similar drug, just slightly more longer acting and has been used in other blood conditions, not so much in this one. So now we have, for the newer patients, we are trying to use more of the Ropeg than the Pegasus, and the patients who were already on Pegasus, we are using that drug. And we are trying to make dose adjustments so that we don't waste a lot of drug.
Okay, that's great. Are there any new therapies or clinical trials available in Canada for CTCL patients?
Currently, we don't have any clinical trials that we are running in Canada that I'm aware of, but there has been talks of maybe some other clinical trials that we can bring in here. There's also some other centers in Ontario that I have had a chance to speak to some of the people, and they're looking into PD-1 inhibitor trials, if possible, that we may have in the future. But currently, as far as I understand, there's no clinical trials available in Canada.
Okay. Let's see if there's any other questions. The webinar mentioned it can be challenging to get a diagnosis for CTCL, and we're asking what is being done in this area to improve early detection and diagnostic accuracy.
So a lot of the centers are now trying to have joint rounds with dermatopathology and the hematopathology as well, who do the lymphomas. So more knowledge and clinical scenario of the patient is discussed at these rounds. So having like a multidisciplinary rounds is helping. More and more rounds are being done to kind of help to know that these are patients that if they have ongoing refractory rashes to treatment, that maybe taking more biopsies, the one biopsy may not be helpful, and that you may need 3 to 4 biopsies to get to the diagnosis. So increasing awareness through certain programs like the CTCL as well has a program now that we're trying to increase awareness of the patients as well to advocate for themselves, as well as the awareness amongst the pathologists and the dermatologists to try and do more biopsies.
Okay. This patient says, I've been experiencing significant fatigue since starting CTCL treatment. What strategies or resources are available to help manage this?
So for the fatigue, a lot of it is to do with the disease itself because of the excessive itching and other things that can cause problems with sleeping and maybe increase fatigue. A lot of treatments such as ECP, where there may be some blood loss, and because of that they're anemic, or interferon or chemo will cause some anemia, and that causes fatigue. So a lot of it is to do with the disease plus the chemotherapy or the treatments that they're getting. And so there's not a lot in terms of that, but if they can have a better sleep, which try and taking some antihistamines which are sedating at nighttime, so that might help with better sleep, or some patients have excessive itching, and to try and do something like wet wraps around their body, which is like sit in the shower for about 10 minutes, and after coming out of the shower to try and put some warm or damp clothes on the body, like after putting steroid ointments, putting a damp cloth and then covering it with the dry clothes and then lying down for an hour with that. That kind of helps absorb a lot of the steroid ointment, and that helps with the itching, and that might be one other thing. Exercise on a regular basis, and it's do acknowledge that it's hard when you have all these skin issues and fatigue, but exercise also helps, hydrating yourself and eating healthy. Those are some of the things that we would suggest that would help alleviate the fatigue.
Okay, great. So we'll continue on. How often should patients be monitored for disease progression or recurrence?
So it depends on the staging of the patient. So if they are stage 1A, which is a very early stage disease, the patients should self-monitor for any new rashes, new lesions, any thickened plaques or tumors. And if they notice any, they can definitely bring it to the attention of their hematologist or dermatologist that they're following up with. But typically for the early stages patients, we may see them once every 6 months to a year. And the ones who are more aggressive, we probably see them every 1 to 2 months or 1 to 3 months, depending on what treatments they are on and how bad the disease is.
Okay. And how do you decide when to move from skin-directed therapies to systemic treatments?
Again, it depends on the staging and the response to the skin-directed therapy. So if the patient has very thin patches and they are, just or some just occasional plaque, we might just do skin-directed therapy plus minus radiation. And if they're not responding to that, then we may switch to the more systemic treatments like interferon or other whatever is available at the current time. But for more aggressive disease at the beginnings, such as stage 2B and higher, they start with systemic treatment usually right away.
Okay. So this next question is, what are the side effects of total skin electron beam therapy? And can you explain how it works, how it targets only the skin layers without affecting the deeper tissues?
So the total skin electron beam therapy is radiation, which is using electrons and not radiation therapy. And so it just basically penetrates just the superficial skin. So basically the epidermis and dermis, which is the layers of the skin, and it doesn't go deep into the organs. And therefore the side effects of radiation that most patients have with other cancers are not seen with it. Total skin electron beam radiation is radiating the whole body with those electron therapy, but it can cause some burning sensation. It may open some of the wounds in some patients if the burning sensation is too much and they're scratching and cause a risk of infections. But these are all very short-term risk. In long term, there may be a slight increased risk of other cancers, like in terms of skin cancers, but it's not a very high risk. It's very well tolerated for most patients, and most patients respond well to the treatment, depending on the stage.
Okay. And why isn't the total skin electron beam therapy available in other provinces, such as Alberta? And what circumstances would a patient be referred out of province to receive that type of treatment?
So again, it all depends on the expertise available and funding more so than anything else. And so in Alberta, we know that we likely have expertise to kind of do the treatments, but we just don't have funding for that. And therefore is only available in a few centers in Canada, and we refer patients for that. So typically the patients who are referred for TSEBT are the ones who have extensive skin involvement and is not responding to the topical treatments or maybe some of the systemic treatments like interferon, and may have a good response. But if they're later stage diseases, they're not. And the other patients who are referred for this is the patients who are now referred for allogenic bone marrow transplant. And as a part of the transplant kind of protocol pre-transplant, they are also now referred for TSEBT to other provinces.
Okay. This next question, you may have already answered it, but I'll just read it back out. I have a hard time sleeping because of the itching and skin discomfort. What can help me get better rest while dealing with these symptoms?
So as I said before, with the fatigue, exactly the same kind of answer for the same thing. It's like trying to use some sedating antihistamines that might be able to help with the itching and sleep as well, such as Benadryl, or using some wet wraps if you can do that, so that it helps prevent the itching the way I described it. And sometimes if the itching is really severe, some patients are started on medications like gabapentin, which helps with the itching as well.
Okay. And looks like I have one more question. For patients who have been through multiple treatments over several years, how do you help manage the cumulative side effects that can build up over time, both, I guess, physically and emotionally? And then are there ways to minimize long-term damage or improve recovery between treatments?
It's a tricky question. I mean, there's a lot of side effects, and we kind of start monitoring for side effects each time we start patients on chemo, and monitor their blood work on a regular basis, such as the liver enzymes, the kidney functions, and their CBCs to make sure their counts are not dropping. And when we are doing regular follow-ups, we just make sure that these labs are monitored on a regular basis. Since dermatology is always involved, we just make sure that there is no other lesions that are different than the MF or the Sézary lesions that are appearing, which suggests of any skin cancers. So those are some of the things that we can do, and then obviously going for regular screening, which is age appropriate for malignancies or other things. We also try and use medications or minimize the toxicity by, trying to using the combinations that are safe enough so that the toxicity is not as bad.
Okay, that's great. Let's see here. Are there certain genetic factors that increase a patient's risk to get CTCL?
No, I think we talked about this. This was a very first question.
Very first question we asked. Okay. I don't see any other questions in the chat. I'll just give it a moment and see if anyone else has anything else to put in. It's a bit more of a quiet group today. I think we've answered all of the questions. So we may have to conclude a little bit early our session. And just as a reminder, this session is recorded so that it can be reviewed at a later date. Will be posted on our website. I'd like to thank Dr. Meenakshi Taparia for taking the time to participate in today's Q&A. And we hope that watching today learned something new about this type of lymphoma for themselves or for your loved ones. If you have any more questions, Lymphoma Canada will be hosting a separate Q&A on October 30th as part of our Ask a Lymphoma CLL Specialist Q&A program, where patients can submit their questions in advance and register for the live webinar to hear answers directly from our experts. For more information and to submit your questions or register, visit our website at lymphoma.ca. With that said, please tune into the next session that's starting at 6:30 Eastern Standard, Accessing Clinical Trials in Canada, which will be starting, as I said, in the next few minutes. Thank you.
Thank you. Thank you for having me. Bye.
Thank you for, bye-bye.